Of hearing loss. The first type is conduction hearing loss. Conduction. Alright, conduction hearing loss is caused by an interruption in sound waves due to an obstruction. An interruption in sound waves due to an obstruction. So that would be such as that bead that a child put in their ear, or a lot of wax build up, or a really bad ear infection could cause that. Okay, so some kind of obstruction. All right, sensory neural hearing loss is damage to the hearing center in the brain. Okay, so it's a nerve issue. My niece has sensory neural hearing loss in one of her ears. And what happened is that while she was being formed in the womb, one of her nerves never joined. They never came together. So she has sensory neural hearing loss. There's not anything you can do about sensory neural hearing loss unless it's a cochlear problem. You have the cochlear implant. But for her, hers is a nerve issue, so there's nothing they can do about it. So sensory neural. So it's damage to the hearing center of the brain. And then there is mixed. And mixed hearing loss is a combination of the two. You can actually have sensory neural, which is that damage to the brain, hearing center of the brain, and conduction hearing loss, which is a obstruction of some sort. All right. Now there are two ways that we test hearing loss. By Weber's. It's called Weber's, and one's called Rinne's. Weber's and Rinne's. Okay. We use a tuning fork. Now, unfortunately, you're not going to have any tuning forks at the hospital unless you're on a neurological floor. If you're on a neuro floor, then they might have a tuning fork. Other than that, you're not going to see them very much. So the way that you can test hearing in your patient is just by whispering, the whisper test. You can actually get behind them so they can't see your lips moving, and you can actually see how loud you have to talk in order for them to be able to hear you. That's really about the only way you can test hearing in the hospital. All right. I'm going to show you how to do this in just a second. No speech by the age of 2. No speech by the age of 2 may indicate a hearing loss. Now, it may also be other things like autism and some of those other neurological issues, but one of the things it could be is hearing loss. When you're looking at the ear, not only are you testing hearing, but you're also looking for any nodules, any bumps or lumps. So you're inspecting the ear as well. Any drainage coming from the ear. Okay, so not only are you testing the hearing, but you're inspecting the ear itself, making sure that the ear looks normal. One of the signs of Down syndrome, you've probably heard this before, but one of the signs of Down syndrome is that the top of the ear is lower than the outer canthus of the eye. If you measured your ear and you followed your ear, it should be even with the outer canthus of your eye. So children with Down syndrome, their ears are low set. That's a sign of Down syndrome. Low set ears. So you want to make sure, you're looking at where the ears are placed on the body as well. Okay. Now, we will not be teaching you how to use an otoscope. We do have some. You can play with them. That's a skill that's a little higher than just an RN level. That's a practitioner level. but you can play with them. And we've got some in the lab you can play with. The reason, though, that I wanted to show you this slide is to show you what a normal tympanic membrane looks like. It should be pearly gray, shiny. Okay. If it was infected, then this tympanic membrane that is clear and nice pearly gray would be red and inflamed. You may actually see a hole in the ear. You know, when they put tubes in ears, they make a little incision in that tympanic membrane and they put a little tube in there to drain the infection out. That's what tubes are. That's what a normal tympanic membrane should look like.
When the tubes come out, because I know they can just fall out of
They can.
children, does that
It will
hole,
peel back
does it
over.
close?
It does. It does. It'll peel back over. Sure will.
But
All right.
each time it heals over, it leaves scar tissue.
It does. It leaves scar tissue. And that's one problem with children who have frequent ear infections, is that it does cause scarring of that tympanic membrane, and so they do have a degree of hearing loss. What would that be? What do you think? Would that be conduction or sensory neural? Scar tissue. Conduction. It would be a conduction problem. The scar tissue buildup would be a conduction problem. All right, so let's talk about Webers and Rinnes, and this is kind of fun. I only have 4 tuning forks, but I'm going to pass them around and let y'all play with each other, or you can do it yourself. When you're playing with a tuning fork, you need to make sure that you only hold the stem of the tuning fork. You don't hold it here, okay? So you hold the stem, and then you hit it on your hand. You hear that little ding, okay? If you hold it with this part with your hand, it stops the vibration, okay? So Webers, the first one, tests for lateralization of sound. So what we're doing is we're testing to see if you can hear equally out of both ears. Okay, so that's lateralization of sound. All right, so I'm going to hold the stem of the tuning fork, hit it against my hand, and I'm going to put it on top of my head like an antenna. Okay, and you should be able to hear the vibrations in both ears equally. Okay? Now, Rinne's test is the same type of principle. You hit the tuning fork part with your hand and make it vibrate. But what you're doing is you're hearing for conduction. You're listening for conduction. Air and bone conduction. Does everybody know where that little bone is behind your ear? Okay, feel that little bone behind your ear? What you're going to do is you're going to actually stick the stem of the tuning fork while this is vibrating on that bone. And it should sound like your teeth are rattling. That's called bone conduction. Air conduction, all you do is when you hit the tuning fork, if you put it up next to your ear, you should be able to hear the vibrations. Okay, so bone conduction, you hit it, and then you put that little stem on your bone. It's going to feel like your whole head's kind of vibrating. Okay, so you're going to do that on both sides. Okay, so I'm going to pass these around and let y'all play. Oh, we're talking. I've got 4, so I'll start 2 at the front and 2 at the back. Hear it? No, hit it really hard against your hand. Get good vibrating. Hit it on the side. Like this. No.
Yeah.
Like that.
Well, I got a weird thing.
Now you hear it?
Yeah. I feel it more.
Yeah.
Okay.
Okay, so while everybody's playing with those, let's keep talking. All right. The next sense that we're going to test is olfactory. We're testing the sense of acuity of smell. The acuity of smell, which is probably, remember we talked about that's one of the tools in our toolbox that's not so fun. So when we're testing someone's sense of smell, of course you want to make sure that their eyes are closed. If you bring something up to them to smell and their eyes are open, well, even if they can't smell it, they can tell you probably what it smells like. Okay, so you want to make sure that they can't see as you're testing it. You can use whatever you have available. One of the easiest things to have is an alcohol swab in your pocket. Have them close their eyes, open the alcohol swab, wave the alcohol swab in front of their nose and ask them to tell you what they smell. What else could you use? A flower, if somebody had gotten flowers, have them smell that. Food. Anything that you have on the unit that you can grab. But again, alcohol swabs are probably the easiest thing that you got. Okay, so the sense of acuity. We're also checking their nose and making sure that there's nothing up in their nose. You're looking at the shape of their nose, the color of their nose, any inflammation in their nose, drainage. Seeing if there's any deviations. Maybe they had a broken nose at some point. I'm just going to put smell and object. Okay. So it's an easy one to test. Patients who have sinus infections or colds, or if they've had nose surgery, anything like that, they're going to have a harder time smelling than someone else that hasn't had any problems. Okay. Oral. Again, these are using a couple of different of our cranial nerves. First thing we're going to do is test acuity. We've been testing acuity, right, of everything else. Eyes, ears, nose, and now the mouth. Acuity. And just like when you're smelling something, you're just going to use something you have on the unit and have them taste. Have them close their eyes and open their mouth and just stick something in there. If it's a potato chip or a pretzel, something sweet, a sweet tart or something like that. It's a good idea if you can offer them two different types of, something sweet and something salty to kind of alter the flavors. Because, some people can't taste sweet things, but they can taste salty things. So you want to try to alter the different types of foods. Swallowing. Now, we talked about this yesterday. When can you test their ability to swallow? While they're eating breakfast, right? That's good. And you can also ask them what their food tastes like at that point too. The only problem with that is that they've seen it. So it's a little different because they don't have their eyes closed. Okay, so having them swallow. The sense of speech. Making sure that their speech is not garbled, that it's clear. And, again, as you walk in the room and say, my name is Emily, I'm going to be your student nurse today. And they say, my name is so-and-so, and I'm going to be your patient today. Well, then you're checking their sense of speech. So you're able to tell whether or not their speech is clear, if they understand what you're saying to them. Okay. What else are you going to look at while you're looking at the mouth? Their teeth. Any ulcers or any kind of, lumps or cracks or bumps. One thing that you also want to check is to make sure that their palates are intact. Now, we do this on babies all the time, on newborns, to check for cleft lip and palate, but you can also do it on adults to make sure that there's nothing wrong with their palate. You know that we have two, right? We have a soft palate and a hard palate. What's in the front? The hard, and the soft is further back. Don't gag yourself. But the soft is, of course, further back. You're going to have what on your little hands? Gloves. Do not stick your hands in somebody's mouth without a glove on. That's nastiness. Okay? Take your finger, and if you run it up the roof of their mouth, you can tell whether or not their palate's intact, making sure there's no holes or anything like that, any lumps or bumps or anything like that. Okay? So making sure their palate's intact. They should also be able to move their tongue. So you can ask them to stick their tongue out at you. So if they stick their tongue out, have them move it up and down. And side to side. Making sure those movements. Can anybody curl their tongue? Some people can, some people can't. But that's not a sign of neurological intact. That's a sign of being gifted. That's what I always tell my child. He and I always stick our tongues out each other and curl them. So, what else are you looking for on the tongue? What if they are a patient who's had a lot of antibiotics or they've undergone chemotherapy? Thrush. If they have a white coating on their tongue, that could be an indication of thrush. They're probably also going to complain of pain because thrush hurts. If you've ever had a baby that had thrush, they cry, 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 cry. It's very, very painful. Okay. All right, so let's put these on the board. Cranial nerve 7 is facial. Another thing that you can have them do while you're looking at their face, because that's what we've really talked about. And when you're doing your assessment, just hit, when we're talking about head to toe, because everybody gets they get really nervous and they're like, oh, I'm going to miss something. Start at the head and just work your way down. Look at their face. What am I going to assess on their face? Their eyes, their nose, their mouth, their ears. Do everything up here before you move down. Try not to skip around, and then you'll remember everything. Okay, so something else you want to do is have them puff their cheeks. Have them frown and smile. Because those are testing what? The muscles of the face. So that's something else you can do with this facial nerve. I'm just going to put movements. Cranial nerve 7, the facial one, also is that taste test. Okay, cranial nerve 9 is glossopharyngeal. Long word. That's your swallowing test. This can also be your swallow. You're all really doing all of it at the same time. Okay, and then let's see. We talked about, 12 is hypoglossal. Sorry, I'm down here at the bottom. Hypoglossal is your swallow. Movement of the throat. And then 10 is speech. That is your vagus. Is this helping? You're kind of getting everything? Okay. Getting there. All right. Tactile sensation, the sense of touch. The sense of touch. This is cranial nerve 5, which is trigeminal. Sensation. What you can do, you're testing their sense of sensation, sharp and dull. One of the easiest things to do is take a tongue blade, snap it in half. You've got a sharp end in and you've got a dull end. Have them close their eyes and have them randomly test the sharp and the dull on each limb, on their feet, on their hands. So as they're having their eyes closed, you say, tell me whether or not this is sharp or dull. But you want to alter. You don't want them to guess where you're going next. So if you do an arm, do a leg next, and then do the opposite foot, and then do the opposite hand. You see what I'm saying? So you're alternating sharp and dull sensations. You're not injuring someone, right? Don't take a pin and jab it in them or anything. And then the last thing is perception. Perception. And this is a sense of position. Sense of position. So the way that you're testing position, while their eyes are closed again, you're having them, you're lifting their foot up and down, their toes up and down, their fingers up and down. People who have neuropathy, like diabetic neuropathy, have lots of problems with this. They have a lot of problems with perception. Have you ever known anybody that had that was diabetic and broke their toe and never knew it? You'll hear those kind of things because they don't feel it. Patients who have had a stroke have a problem with perception or position. So as they're lying in bed, have them close their eyes and just move their digits up and down, their toes up and down. See if they can tell you which toe it is that you're moving, if they can feel that movement. Okay. All right. Why don't we take a little break and come back? So I'm going to set up the computer. When you come back, I want you to oxygenation, ventilation, and now get to use your stethoscope. Yay! Are you excited? All right. So the first thing that we need to do is to remember your anatomy and physiology. You need to remember your test wall landmarks. That's going to be very, very important to this section. So you do remember, hopefully, that there are 3 lobes on the right and only 2 on the left. Correct? I remember that. When we're talking about anterior, that's this side. Posterior, of course, is the back. I hope you know that. And then lateral is the sides. Okay? So when we're listening to breath sounds, we're going to be listening to the front, the back, and the sides. So just remember that, anterior, posterior, and lateral. Okay, let's talk about some of the principles, though, of ventilation and perfusion. First off, rate. What is a normal rate?
20 to 22.
Y'all are
12 to 20.
12 to 20. 12 to 20 is a normal adult rate. Now there are some terms that you need to know that means an abnormal rate. Okay, so if we've got 12 to 20, all right, bradypnea would be what? Slow. Less than 12. Tachypnea would be greater than 20, breathing fast. And of course, apnea, we just might as well go home, right?
Yeah.
No breathing. Periods of no breathing. That's a bad thing. Hopefully everybody does realize that. Apnea, bad. Okay, and a lot of things can cause a change in rate. Stress, medications, age, temperature, if you have a fever. Remember we talked about that. When you run a fever, you have an increased respiratory rate. Okay? But when you're describing rate, it's either normal, between 12 and 20, or it's bradypnea, tachypnea, or apnea. Depth. Depth is measuring the excursion or movement in the chest wall. Excursion or movement in the chest wall. Okay? So when you're describing the depth of someone's respirations, they're either deep, shallow, or normal. And I really hesitate to use the word normal because, what is normal? I mean, nobody's really normal. But when you're thinking about these kind of terms, somebody who's breathing deep, when you think about the depth, a deep depth, think about somebody who's been exercising for a while and they're breathing really hard and they're really sucking in the air. That's deep. Someone who's breathing shallow, if somebody's in pain, they tend to breathe really shallow. It's like, so they're really not moving their chest wall at all. Okay, rhythm. It's either regular or irregular. And you can observe the rhythm of someone's breathing in their chest or their abdomen. And then the last principle of ventilation and perfusion is diffusion and perfusion. And you use that by measuring O2 sat. You're measuring the amount of oxygen in their capillaries. Now, there is a term called clubbing. Have you heard the word clubbing of the fingernails before? Someone who has chronic COPD or chronic lack of oxygen, like if they have frequent bouts of congestive heart failure or emphysema, something like that, their fingernails are going to appear clubbed. And what that means, and there may be a picture in your book. Oh, you'll have to look. But there's what it looks like, and don't laugh at my drawing. Here's your finger. The nail bed rises up, whereas it should be straight and flat. It looks like it's curved. It rises up. So if you look at your fingernail, it should be flat. Somebody who has a chronic lack of oxygenation, that fingernail is going to have a bump in it. It's going to be clubbed. All right, let's talk about breath sounds. There are different types of breath sounds. Okay, and I've got the first one starred because that's the term that you hear most people referring to normal breath sounds as vesicular sounds. Vesicular sounds are very soft, they're very breezy. That's that inspiration and expiration. Everybody knows when you're measuring someone's respiratory rate, and inspiration and expiration is 1, right? Everybody understand that? Remember that? Bronchovesicular and bronchial sounds are those 3 sounds are all normal, but it's where you're hearing them. Bronchovesicular sounds are more medium pitched and blowing. And then bronchial sounds are very loud and high pitched. You hear bronchial sounds up here in the throat. They're very loud.
You say high pitched?
High pitched. Okay. Now, I'm going to turn the slide because I want y'all to look at this, and hopefully you have this picture. Remember I told you I put all those pictures up? This is one of those pictures that I put up. And I love this one because it gives you an idea of those 3, what we call adventitious sounds. Adventitious lung sounds are sounds that are bad, that are wrong. There's something wrong. We have 3 types: crackles, bronchi, and wheezes. Now there are sounds called rails too, but we're not going to worry about rails. If we can get wheezes, crackles, and bronchi down pat, we're doing good. Okay? Crackles sound like Rice Krispies. If you're listening, you remember how you put milk on Rice Krispies and it makes that popping sound? Everybody ever heard that? Mm-hmm. Yes, has anybody not heard Rice Krispies? That's like a classic. Speaking of sounds, and this is totally off the subject, I learned something really cool the other day. And I was telling my boyfriend about this last night, and he looked at me like I was a lunatic. do y'all remember in Star Wars the sound of the lightsaber? Do you know what made that sound? You know what they recorded to make that sound? Hummingbirds. That's the sound of a hummingbird up close. I thought that was pretty cool. He just rolled his eyes at me and kept walking. I thought that was cool. My 8-year-old son is really into Star Wars right now, so. Anyway, okay, so crackles. See, that's something you can go home and tell what you learned at school today, that the sound of the lightsaber is a hummingbird. That will not be able to test, no. Okay, crackles. Crackles are the sound of Rice Krispies. The difference between crackles and ronchi, because when you listen to the two, you're going to have a very difficult time distinguishing the two. Okay? Crackles are not cleared by a cough. And so if you hear that crackling and popping sound when you're listening to someone's breaths, you ask them to cough. Say, can you give me a good cough? If the sound when you listen again is still there, that's a crackle. That's how you distinguish between the two. Ronchi are cleared with coughing. So if you listen, you hear all that crackling and popping, you say, can you cough for me? And then you put your stethoscope back on their lungs, on their chest wall, and you don't hear anything anymore, that's ronchi. So that's how you distinguish between the two.
Ronchi sounds like crackles also?
They do. They're very similar. Now, up here it's going to say that it's coarse like a snore, and it does, but you may hear that popping. And so I'll have a lot of students that will listen, and they can't tell the difference between the two. So that's the way to tell. Okay? Crackles are not cleared by cough. Ronchi, they are cleared by cough. All right? And then wheezes are very musical. Wheezes, that's your asthma kids or asthmatic adults. Anybody in here have asthma? Okay, my little boy has asthma as well. It's asthma season. Woo! So those wheezes are going to start. The wild wheezes, that's what we call them at the hospital. The wild wheezes are getting ready to start. And you'll hear a musical sound. Now I'm going to let you hear some breath sounds. So hopefully you're going to have to be real quiet. Hopefully we're going to be able to hear over the sound of the air conditioner.
Non-musical sounds. They may be classified as high or low pitched. High-pitched crackles are also called fine crackles. Low-pitched crackles are also called hoarse crackles. Listen now to high-pitched crackles.
That's rough. Here, it's not popping. Did you hear it pop there? It really does. Okay, let's hear low-pitched crackles.
Now listen to low-pitched crackles.
Can you hear him breathing in and out?
Crackles are due to the sudden opening of very small airways. Listen again to high-pitched crackles. listen again to low-pitched crackles.
Okay, let's listen to wheezing. They can. Have you ever had, anybody ever had pneumonia, or you feel it when you breathe? They feel tight and they feel like popping.
The crackles, I know you can't hear them by talking about it. They go away and come back.
No, they're always there until the whatever is causing them goes away. This is your patient's pneumonia, congestive heart failure, any kind of fluid or infection.
I also have
Uh-huh.
so at night,
Uh-huh.
my lungs are always working. At night, I can only hear crackles.
Yep. What's your blood hearing bronchi? Because they're so close in nature, bronchi do go away and come back. Yeah. Interesting. So how do your lungs go right now? We might use your guinea pig.
I'm good right now.
You're good right now. Darn it. No, that's good.
I'll let you know.
That's good. Right. Whatever, just listen. Okay. No, I'm glad you're good, honey. Okay. Wheezes.
I got a question.
Y'all got something.
Listen now
Hold on,
to the
let me
sound
pause
of wheezing.
It's so riveting. Listen.
Will you hear it when you inhale and exhale?
You will.
Okay.
You will. Especially crackles. Now, bronchi you may only hear on inspiration or expiration, but crackles you will hear both. They're continuous. Okay, here we go. Rick wheezing.
Whale sound?
Sounds like a whale.
Sometimes called a rhoncus, is a musical pulmonary sound. The musical character is determined by the spectrum of frequencies that make up the sound. The lowest frequency, called the fundamental,
so excited
sets
to
the
listen
pitch
to
of
the
the
lecture.
wheeze. Wheezes may be described as high-pitched, in which case they are also called sibilant bronchi,
You don't
or
need to worry about
low-pitched,
that.
in which case they are also called sonorous bronchi. Listen to a high-pitched wheeze.
It's typical asthma. That's what you'll hear. See, it's louder on inspiration for that than expiration. You can hear the wheeze on expiration, but it's not as loud. That's caused
Now
by
listen
narrow
to a
airways.
low-pitched wheeze.
It's real, kind of muffled sounding. That's just on inspiration. Okay, so that was a very good question. Jeff asked, I'll get y'all's names eventually across. That was a very good question that he just asked, what is causing it? And what is causing it is a narrowed airway. So wheezes, the airway is closed, it's narrowing off. And the wheezes, the crackles and the bronchi are caused by either infection or fluid or something like that. Let me see if I can find it real quick. Just bear with me a second. This is something else that's getting ready to start up is Strider, or is croup. This is a really good sound of anybody ever had a child with croup? Ben used to get croup all the time. Croup sounds. Croup is very upper airway. It's right up here. It's right up in the trachea. Okay, it's very, very loud. And it sounds like a seal barking. When you hear a child with stridor and croup, it just makes you want to cringe, and it makes you want to do something, just jump on it immediately. However, there's really not a whole lot you can do. Croup is a viral thing, so it has to run its course. But we bring them in. We do a lot of some moisturized air. The best thing to do with the child with croup at home is I always would steam up the bathroom, not get in the shower, but we use the shower to steam up the bathroom, sitting there in the steam, in the warm steam, and then take Ben outside in the cold air, and then come back in the steam, and then go outside in the cold air. And that rapid change in temperature calms that stridor down. So stridor can also be caused by something that has swallowed something and it's blocked the trachea, blocked the airway. I always use this clip. You hear? She'll get up close so you can hear. One thing I want you to see too is you see how that child is, she's breathing deep, like she's got retractions of her chest muscles. That's what that mom's trying to show you. It's kind of hard to see, but
You can hear the wheezing too.
you can hear it's all up in here. It's all up in here. And you see how they breathe. They're very, child with croup and with stridor, it's all up in here. They're really got their mouth open. You hear? So I want you to hear the difference. That's all up in here. And croup, being virus, causes these airways to narrow, and so that's what's causing that sound.
So maybe then out of the
Will stop that. It'll reduce that swelling, and it'll help to ease the cough, that bark. Yes, it's a beautiful sound, isn't it?
Now the barking, his cough is from the irritation though, right?
Right, it's from the irritation. They do sound like a seal. That's what they sound like, that seal bark.
Now with an anti-inflammatory, help
Sometimes if it's severe enough, they'll give an anti-inflammatory, but they'll do anything, not even breathing treatments unless they're really in distress. There's not a whole lot you do there. It'll run its course. But I want you to hear what that sounded like. So you hear the difference though, because it's upper airway versus what we were hearing earlier was in the lungs. Alright. Let's go see if there was any other interesting sounds for us to hear. Let's see if we can hear one.
Can adults get that?
Hmm?
Can adults get croup?
Yes. Not, well, they can get stridor, not croup. Croup is virus that's just, it's just typically under the age of 2. Most children are under the age of 2.
Is it because our bodies will just fight it off?
Yep.
Yeah. What's the difference between stridor and croup?
Nothing. Croup is the actual virus that causes stridor. Stridor is the sound.
Well, then does senior citizens get that?
No. They can get stridor, but not croup. Stridor is the sound. Stridor can be caused by a lot of different things. Croup is... What the world that is. Let's see. Bronchi is what they're saying that is. practice. I mean, it takes a lot of practice to know how to determine what is what. But again, the biggest thing between crackles and rhonchi is cough. Crackles are not cleared by cough. Rhonchi are cleared by cough. If you've got anybody in your family, or you work in a nursing home, or you know somebody who has congestive heart failure or emphysema, any of those conditions, listen to their lungs, because they're going to have some odd sounds. Right? COPD would have, they're going to have some wheezing. You're going to hear more wheezing. Okay, so let's talk about now where we listen. And everybody always laughs at this because they say, well, we go to the doctor, they don't listen 26 different places. However, we're going to teach you that there are 26 locations when you're listening to auscultative lung sounds. Okay? You should, if you want to get an accurate sound and make sure that every lobe is listened to in every place, you want to use 26 locations. Okay? So, there are 10 on the back. All right, there are 10 on the back. Now, when you're listening on the posterior side, you want to make sure that you are missing. Oh, all right, fire drill.